So yes, the hope is to, in sort of relatively quick time, cover most of what you need to know about cavernomas. I'm sure there'll be a lot of questions still relating to that. There's a few provisos I need to give going into this. I suppose first and foremost is that there are lots of different types of cavernomas, and there's lots of people obviously on this meeting with cavernomas, and different examples don't necessarily apply from one person to the next. And so I'm going to describe all the different possible things that can happen and all the things that are out there, but that doesn't necessarily they are common. And indeed, you have to bear in mind what is common in all of this and what is not. The other thing to say is I do show a few pictures of operations, not very many, but if you're squeamish, then look away, I guess, but I don't think they're too bad. So in broad terms, I'm going to tell you basically what a cavernoma actually is, which is always quite hard to get your head around. Then we're going to talk about how they behave and what they do. And then we're going to talk about what treatments there are or are not for them. So to be able to talk about what they are, I do go into a little bit of sort of the anatomy of things and actually compare them to normal blood vessels and other things that can go wrong with blood vessels, mainly to try and understand what they are. And so the first thing is you've got to understand how blood vessels normally work. I should check, can you see my pointer if I'm pointing on things on my screen? Joanna, can you give me a thumbs up or down if you can see my arrow on my screen or not? Yes, okay.
I can do.
So blood vessels go to the brain or to any organ through an artery, which is a big filled blood vessel under pressure. And then they flow out of the brain through a vein, which is also a big blood vessel. But these are under low pressure because in between you have all these very fine blood vessels, the capillaries, and they essentially dissipate the pressure. And the relevance is that when things go wrong with blood vessels and you get abnormalities of them, there's a big difference if they're under high pressure, because it rather makes them more dangerous, or if they're under low pressure. Now, probably the most common type of blood vessel abnormality in the brain, and certainly in terms of people's awareness of it, are brain aneurysms. And this is a picture showing a brain aneurysm where you get a big blood vessel coming up from the neck into the head, and then you get a little blister off one side like a little balloon. And those can sometimes burst and cause bleeding on the brain. Now, because they're on one of the main arteries that's big and it's under high pressure, they can give quite significant bleeds with quite a lot of disability related to that. That's different from probably the next best known blood vessel abnormality of the brain, which is called an arteriovenous malformation. And a picture of the normal situation here again on the left, where you've got the red arteries going via the little capillaries into the veins. In arteriovenous malformation, you basically get big blood vessels connecting the arteries to the veins, and you get the pressure transmitted through those blood vessels around to the veins, and therefore the veins are rather liable to burst and cause, again, relatively severe bleeds. So that is all designed, well, sorry, this is another picture of an AVM showing a similar sort of thing, whereas in the previous picture, sorry, I've lost my arrow again. Here it is. It's just a single blood vessel that connects from arteries to veins. In this picture, you've got this whole tangle of big blood vessels running from artery to vein. So then on to what actually the talk is about, which is cavernomas. And cavernomas are a problem somewhere essentially in this fine network of microscopic blood vessels. So it's not really an abnormality of the big blood vessel going in, not really an abnormality of the big blood vessel coming out. It is in this fine network of microscopic blood vessels. And the way people draw it is in this diagram at the bottom here. So there's other bits on this, there's a scan of cavernoma here and a depiction of a brain with a cavernoma. But the bit I'm focusing on is the bottom here. And that shows how you have an artery coming along that runs into these tiny little capillaries. And you can see the vein draining out with the tiny little veins going into it. And in between, you have this thing of these little nodules, and they're essentially little empty, little sacs of blood under low pressure that's come under low pressure out of the capillaries. And that is the cavernoma, basically. I hope that wasn't too technical, but the main thing is it's an abnormality of the microscopic vessels. This is just depicting, whereas in here, it's just on the surface of the brain. They can happen in different locations. And this picture is a picture of, if you look at the side of the head essentially, and here's one sitting in the brainstem, the main bit that comes out of the brain. We'll talk about that in a bit. So that's roughly what a cavernoma is. This would be a picture of a fairly typical cavernoma. So it's a very small blemish sitting here. So this one will be in the sort of 5 to 10 millimeters, you know, a large pea sort of size. This one went forwards to surgery. And this is a picture trying to show that. Unfortunately, everything happens under the microscope. So it's sometimes quite difficult to disentangle if you're not used to what you're looking at, what you're seeing. So these bits of metal are just instruments. So these two are instruments. And this is a retractor pulling the skin out of the way. Along here, you see the edge of the bone. So that's bone there. And the edge of the bone is running around like that. We made about a 2 centimeter opening in the skull. This bit here is the lining of the brain called the dura, which is like a thick leathery lining around the brain. And that which sort of a little square is open roughly in that sort of shape. Here's a bit of the surface of the brain. And then inside here is this little nodule, bit sort of darkish, reddish color. And that's the cavernoma. And when you remove that cavernoma, what you see instead is basically whitish, yellowy whitish brain, which is what it would normally look like. And that appearance is often likened to looking like a raspberry. And so the raspberry are like the sort of sacs of blood within it. And you have to, if you imagine the picture that I showed of the artery coming down, going into the microscopic blood vessels that then fill into these bits of the raspberry, and then you have microscopic vessels coming out of it and going into the veins again. On a scan, it looks like this little nodule here, and you can see like the little sort of nodules within it. And probably more descriptively, it might be likened to a piece of popcorn. Doctors like likening things to food. And yeah, that's exactly what it looks like there. And they can appear in any part of the brain, basically. And here are some examples. This is in the medial temporal lobe part that's particularly associated with seizures. This is one in the front of the brain, a bit like the other one, but this one's quite unusual in that it is grown. So these are 2 different scans at different times. We can see that there's a change in size. I should say that's really unusual. We can talk about that a bit later. This is another one. It's again unusual because it's big. This is much bigger than you would expect to see in a normal cavernoma. I'd again go back probably in my slides. Slides just sticking, and reiterate, this is the absolutely typical cavernoma and represents the overwhelming majority in terms of size and appearance. That said, this is a big one. This is actually a huge one. This is the biggest one I've dealt with to date. And that's sort of, I don't know, about 7 centimeters in diameter. This is another situation you get with cavernomas. So here, all these little black dots, each one of those is a little cavernoma. So none of them individually is very big, but there are loads of them. And you can, that's a typical example of one that is likely to be genetic. And we can talk about genetics of cavernomas as well. In a nutshell, most of them are not genetically inherited, and you just happen to get one. But an occasional person will have some genes that predispose you to them, and then you get this picture where you might have 50 or 100 of them. And what you do in that situation is a little bit different. This is another image of one. So again, this is the circumference of the head. Then in the center here, you see this outline, which is the brain stem, which is the main relay essentially of information from the brain to the spinal cord. And then within it, you see this bit here, and that's a sizable cavernoma in the brain stem. And that's a very specific type of situation to discuss as well. So I guess next is to really talk about how do they present, so what symptoms they give. Well, overwhelmingly, the most common situation is for them to be what we call asymptomatic or incidental. They don't give you any symptoms at all. They're generally pretty quiescent things that just sort of sit there. They can essentially cause symptoms through one of two ways. One is they cause seizures, and the way they cause seizures is essentially by irritating the brain surrounding them. And if the brain surrounding them gets irritated, that can become overactive electrically, essentially, and that overactivity of electricity can spread across the whole brain, and that discharge of electricity across the whole brain is essentially a seizure where potentially your whole body starts shaking and you can lose consciousness. People often ask about what is exactly that irritation surrounding the brain. Well, it can be one of two things. Sometimes it can just be a little bleed that instantaneously irritates the brain and it gives you an isolated seizure. And sometimes it can be essentially the scarring and the healing in the brain surrounding the cavernoma, and that scar tissue causes abnormal electrical activity, and that causes seizures. If the cause is a single bleed, then there's just a small chance that you might only have one bleed, or one seizure. If it's more the scarring around it, you're very likely to have more seizures in the future. The other way that it can give symptoms is essentially for there to be bleeding from the cavernoma. There's lots of different names for it, so that to try and resolve any confusion, I've put all the different names that you might see. The easy one is a bleed. A hemorrhage is simply the technical description of a bleed. A clot is if you bleed and you've got flowing blood that comes out of the blood vessel that then sets like a jelly, and when it's set like a jelly, that's called a clot. It can also be called a stroke. Now, the stroke is a particularly confusing one. Stroke, strictly speaking, means any time you get symptoms from the brain due to a blood vessel. Now, unfortunately, there's lots of different things that can happen to blood vessels, and therefore there's lots of different types of stroke. Overwhelmingly, the most common type of stroke is where a blood vessel blocks off and a bit of brain dies off. And so when people say stroke, they usually kind of mean that type of stroke. But a cavernoma is a type of blood vessel, and if that was to cause bleeding and give symptoms, then that is also symptoms from an abnormal blood vessel, and therefore a type of stroke, albeit a very rare type of stroke. So yeah, you could call a bleed from a cavernoma a stroke. And then the other thing that people might describe it as is amongst doctors is a focal neurological deficit, which means that a focal part of the brain has stopped working, and as a result, that bit of the brain is not doing the things it's supposed to do. In terms of the frequency of this type of thing, it depends how frequently these things happen, depends essentially on how you initially start. So what your presenting symptoms are. So if you're somebody who has no symptoms and never had symptoms, then the chances of anything happening in the future is relatively low. It depends on the location of your cavernoma. And so if it's outside the brainstem, which is essentially most of the brain, then the statistic is that just under 4% will develop symptoms, whether that's seizures or a bleed, in the next 5 years. If it's in the brainstem, that's a bit higher, at around 8%. And the reason for that is essentially different parts of the brain are sensitive to differing degrees to injury. And it's actually surprising how robust the brain is. And it's really a testimony that evolution has tried creating redundancy in most parts of the body, that you can damage some part of it and still carry on. And that's often a bit of a surprise to people, because they think about a computer, and if you just touch one wire in the computer, the whole thing stops working. The brain isn't like that. It has much more redundancy and ability to deal with some injury. That ability to deal with injuries over the surface of the brain much greater than the brainstem, which is essentially like a wiring network which wires all the different parts together. And so therefore, if you have a cavernoma there, and say you get a little bit of bleeding from it, you get symptoms very quickly and relatively severely. Whereas if it's in different parts of the brain, you get a little bleeding from that, you don't get many symptoms. Actually, quite often you don't get symptoms at all. And so often bleeds from a cavernoma will only show on a scan, and you might never have known that you had it. The other way you can present is with seizures. And so if you present with a seizure, the obvious first question is, what are the chances I'm going to have another seizure? And the answer is very high. So 94% will go on to have a seizure. The ones that don't are probably ones who have a seizure related specifically to the moment of a small bleed, rather than the ones who have it from the scarring around the outside of the cavernoma. The last way you can come to attention is because you've had a bleed from your cavernoma, and then the chances of having another bleed are raised quite a bit. And the numbers often sound quite scary, actually, when you see the numbers. So again, if you have what would be the most common type of cavernoma, which is outside your brainstem, your risk is nearly 20% of having another bleed in the next 5 years. So that's a 1 in 5 risk. If it's in the brainstem, it's probably near 30%. Now, strictly speaking, again, like I said before, there's probably no difference in the number of bleeds that occur in those two groups. The difference simply is that if they're in the brainstem, you're more likely to become aware of them. That said, with the number that I'm describing there, that's a number who have a bleed. That doesn't necessarily mean that they are particularly unwell or can't make a good recovery. And it is the characteristic of cavernomas, as I mentioned at the beginning, compared to the aneurysms and the AVMs, that actually a lot of them give relatively mild symptoms that in a lot of cases you can recover from. That's not all cases, but the outlook is a lot better than with most types of brain bleed. So then the question is, what do we do about these cavernomas? So broadly, you can treat them or not treat them. So if you start with not treating them, does that mean you just do nothing? Or do you do some scans in the future to keep an eye on them? And if you do treat them, you need to think about, is it with surgery or this other thing that I'll describe to you, which is radiosurgery? So the first thing to talk about is really doing nothing. And I'll try and put across to you the issue with cavernomas, which is not so much that we don't have any treatments for them. We have 2 pretty decent treatments for them. The issue is that the treatments carry some degree of risk, and the risk posed by the cavernomas themselves are not necessarily that high. And you have this awkward balance that the risks of the treatments are not that dissimilar to the risk of leaving the cavernoma alone. And then super added onto that, there's this peculiarity that generally, as the cavernoma ends up being in more dangerous locations, the treatment, particularly surgery, also gets more dangerous. So the cavernomas that you say, well, they're more dangerous and therefore there's more reason I want to treat this one, happens to also be the one that you're kind of, well, but that's also the one I'm more worried about treating. Whereas the ones that you go, oh, that's easy to treat, when you look at it, you go, but actually that's probably one that's not that dangerous and you could probably leave it alone. And that's the tension that leads to the fact that on average, most cavernomas, we don't end up treating. If we don't end up treating them, the obvious question, I actually did see that in the questions that were submitted, is, well, should we keep an eye on them on scan? And there's definitely something very reassuring about doing that. The issue is largely, what is that scan likely to show, and what are you likely to do about that? So doctors are particularly educated in this way of thinking, that anytime you do a test or you have an action, there's got to be some logical consequence to that action. There's no point doing a scan if actually nothing changes for it. So the 2 things about doing a scan is, first of all, they actually, in the vast majority of people, don't change. There are some specific circumstances in which you might anticipate cavernomas changing. But the vast majority don't. The circumstances in which things you think a bit differently about are in children. So their cavernomas probably grow with children, shall we say, and then stop doing so in adulthood. So that would be a time to think about scanning. Occasionally, cavernomas can be induced by radiation treatment. So people who might have had a tumor at some stage early in their life had radiation treatment for that and then developed cavernomas afterwards. It's another unusual circumstance, but that's a situation where you might say we should keep an eye on that one because those sometimes grow. The other one is potentially familial ones, because familial ones do grow sometimes and can increase in number. But there's some complexities to doing in familial ones, because they're often multiple, so it gets quite difficult to know which or whether you would treat them, but I can talk about that a bit later. Going back to the circumstances in which you do follow them up, there's also the adage that even if you see one change on the scan, if it's not giving you any symptoms, there's a question whether you should treat it. And many people would argue, well, even if it's changed on scan, if it's not made you unwell, then probably just wait and see what happens. And if that's your attitude, then what have you gained by scanning it? But anyway, those are various nuances for very specific situations. The overwhelming statement is very few change. And therefore, the vast majority, if you've got an isolated, single, relatively small cavernoma, we wouldn't recommend following up. So that's the issue about why we don't treat a lot about scans. Now, some we do treat, and we'll get into reasons why you might do that. And there's two broad treatment options: surgery, which is probably easier to understand, and I'll run through first, and then radiosurgery. So surgery, basically, I can get rid of any cavernoma. So if people ask, is there a treatment for this? You can remove any cavernoma. The issue is what is going to happen to the person, and what are the consequences going to be of that surgery. And that really depends on location. And so you can imagine if something is right on the surface of the brain, those risks potentially are a lot lower than the deeper they're in the brain. As an example, this is a brainstem cavernoma. So this is a picture of a head with a nose here, ear on either side there, and the back of the head. Here towards the middle, this is the brainstem again, which I mentioned, which is those cables connecting the brain to the outside world. And this little bit of whitish stuff is a small cavernoma, just in a very unfortunately located location. And so to get to that as an operation, you need to make a cut behind the ear, navigate around this bit of bone, and which contains all the parts for your hearing, slide down here past this bit of the brain, and then get around the corner here and take that out. And that's technically challenging, and probably more importantly, risky. The way that might look in some slides, it's difficult for me to display this without more hand motions in front of an audience, I think. Essentially, you're going to have somebody's feet heading off in this direction, and the top of the head heading off to the bottom of the direction, in the bottom here. This is the base of the skull, and we've removed a corner off the base of the skull. The person's ear would be here, and this is the lining of the brain as it heads down towards the spine. We've opened up that lining around the brain to show here some whitish of the brain, a blood vessel there. This white bit of cotton that I'm using here has pulled part of the brain aside to get down to here, which is the brain stem. This is the brain stem, again with my instruments here having pulled the bit of the brain that's in the way to the side. And you can see this sort of darkish hue here, which is essentially the cavernoma just sitting under the surface of the brain. And here we've made a small opening to take the cavernoma out. And that's what it looks like afterwards. So, that's a brainstem cavernoma. That's what we'd consider technically the most difficult location probably to get to. So it is possible, but you just have to have great insight to what risks you're taking doing it. And so therefore, we typically, for that sort of thing, would only do it in somebody who is repeatedly having bleeds and symptoms from it before you contemplate anything like that. The other treatment option for cavernomas is radiosurgery. It's a bit more nuanced what to say about that. First of all, it's understanding what it is. It's not an operation where your head is opened, even though the word has surgery in it. So it's essentially, I think, in most people's view, a non-invasive treatment. This diagram depicts kind of what the idea is. So there's a patient's head here with a cavernoma in the center. And although it likens to radiotherapy, in radiotherapy, you should just shine radiation at the whole head and you just blast everything. And as a consequence, people feel pretty rotten. The hair typically falls out. But that's all unnecessary in something like you've got a cavernoma, where it's a very specific spot usually you're trying to target. And so what they do is they put your head inside a machine which has radioactive compounds in it, and they can shine rays, and all those rays focus very specifically on that one target. So just that one target gets the radiation, not everything else. And the idea is that that induces a subtle injury in the cavernoma, and that it slowly shrivels up, and the risk of bleeding disappears. This is what the machine looks like. So this would be the bed, the end of the bed here, with the patient sort of lying there and the head going into the machine there. And then this is what the sort of mechanics of the machine would look like. Although from the outside it looks like this, and I always say it doesn't look a million miles away from a cross between a CT and an MRI scanner. To practically go in it, the only thing that's different is that you need to have a frame mounted on your head to keep you still, which is like a circular metal ring, and there's 4 pins that pin through the skin onto your skull, which can be put on under local anesthetic and removed at the end under local anesthetic. And it's done as a single dose, so it's not something that has to be repeated. And its action probably is over a period of a few years that it has its action to get rid of the cavernoma. So it's not an instantaneous thing. And that's just another picture of somebody going into one. The companies love it, so there's lots of pictures online about them. So the thing about cavernomas is about radiosurgery is that it's much lower risk than surgery. It's certainly much more comfortable, and the recovery is much more straightforward. The issue is that whereas with surgery, we know we always get rid of it, with radiosurgery, we don't really know. And part of the problem is because it doesn't disappear immediately, and indeed on scan it doesn't disappear at all, so there will still always be some sort of scar or something where the cavernoma was. It's very hard to prove if it's ever gone, because the way you would prove that a cavernoma is gone is basically by proving that it doesn't bleed again. Now, mostly when we do radiosurgery, we do it after somebody's had a bleed. And I told you earlier that your chance of having another bleed in the next year or two is in the 20 to 30% range. What I maybe didn't say quite so clearly is that over time, that risk lowers and lowers, such that a few years after a bleed from a cavernoma, your risk of having another bleed is 1% per year. So the problem is that the natural course of things after a bleed is that you have quite a high risk in the first year, a bit lower in the second year, third, fourth, fifth year, it's actually very low. If you take a treatment like radiosurgery, which takes typically a couple of years to work, and you give it to some patients, you'll see that they still have some bleeds in the first year, a bit less in the second year, and hardly any in the years subsequent to that. And it's very hard to prove how much of that change is due to the radiosurgery or was going to happen at all. And so because of that, radiosurgery is basically controversial, that nobody really can confidently say it does or it does not work this well. And therefore it's subject to some research, which we'll mention at the end. So that's all the things really to say about treatment. Then I'm sort of going to end by just showing some of the different cavernomas that I showed at the beginning, and just talk about what we now know about them having what I said, after what I said. So this is sort of what I said is the classic cavernoma. This one, I think most typically would give no symptoms. It could give seizures, although seizures are more common the more closer to the surface they are. And this is not a location you would ever operate in. And the reason for that is that this sort of section of the brain is where that controls power in the arm in particular. And so this would be influenced, if you were to operate on this, you'd be left paralyzed down your left arm almost certainly. and the symptoms would have to be pretty bad to consider taking that on. This one is the flip side, so it's on the right side. Sorry, I didn't talk about sides here. Sorry. This is the patient's right side. Scans are always viewed from the incorrect side. You look at a scan always as if you're looking from the feet. So this is on the right side, would control the left side, whereas this is in the patient's left side and would control their right side. So similarly, it's reasonably deep, so you wouldn't operate on that. And on the left side is where speech sits, and so you also take a risk on damaging speech. So again, you wouldn't think about it. This one is right at the front of the brain, the frontal lobes. They're probably the most forgiving parts of the brain. Probably evolutionary, that's the part of the brain that is also most likely to be injured in trauma. So you could remove that reasonably safely. Now, if the image was just like this, then I probably wouldn't take that out because it's still small. So you could safely take it out, but you say it's small, it's probably not going to do anything. This was a relatively unusual one, again, in a young patient, and it, in fact, in a child, and it grew. And therefore, that's unusual, and that would be a circumstance to remove it, and this one was removed. This is a different circumstance, so this is sort of slicing your head through this way now, top of the head up here, and ears on either side. And this is a particular part of the brain called the medial temporal lobe, which particularly presents with seizures. Yeah, that would be overwhelmingly likely the cause of the symptoms that this patient would have. We didn't talk about treatment for seizures earlier, and that warrants some discussion. You know, should you consider surgery or radiosurgery for seizures? It's actually not the obvious thing to do, largely because we have pretty good medications to prevent seizures. It's quite variable from person to person, which ones you respond to, how many side effects you get. But for most people, you'll get good control of seizures with relatively few side effects if a bit of time is spent hunting around, trying out different medications. And that would generally be regarded as a much better solution than an operation that carries considerable risk. The main risk with operating in this area is memory. So that part of the brain has a lot to do with your short-term memory, and you operate in that area. There's a serious risk of that your short-term memory can be pretty poor. In the global, so that's the sort of global view about operating for seizures. You can operate for seizures. It's not it doesn't universally get rid of them, and indeed sometimes surgery for cavernomas in itself can cause seizures. So the net gain is not necessarily that high. And as I say, we tend to focus on anti-epileptic medication. This is an unusual circumstance where you've got what would be considered a very large cavernoma, and it's relatively close to the surface, so that you may well consider taking out. And indeed, I showed you this image earlier of really a giant cavernoma that you may consider taking out. It's still not something that goes without saying, because this goes right down all the wiring that connects this part of the brain, this part, all this here needs to run through wires that run through here to go towards the brainstem. So trying to remove this, you're working through basically everything that connects the right side of the brain to both the left side of the brain and your spinal cord. So there's a really significant risk of leaving somebody paralyzed down the other side. This particular case was again in a child, and he presented just with largely tremor, to be honest, in that side. And oddly, as a surgeon, I don't know how to phrase this in the correct sort of way. In this sort of circumstance, you almost hope your patient comes with some degree of paralysis, because it means that the risk from your surgery, it's harder to make somebody worse. Somebody comes with something like this and they have no symptoms at all, the risks you're taking as a surgeon that you can make them really a lot worse are really quite high, and really ups the ante in the whole decision making quite a lot. This is a circumstance of familial cavernomas, which I mentioned. In terms of treatment, this is actually a situation where you're actually quite unlikely to treat a cavernoma. And the reason is, which one are you going to treat? And there's so many, you're essentially never going to manage it. So there really has to be, in the familial cavernoma situation, a standout cavernoma that either due to its size or its specific location, you're certain is causing symptoms, and you're really certain that you might be able to improve things. So just occasionally you'll have a picture like this, but there'll just be one very large one that you go for, or the other circumstances, you just have one in the brainstem that's giving you symptoms. Then this is the picture of the brainstem cavernomas. Again, this is the circumference of the head. This is the top of the eyes here and here, the ears on either side. And then in the middle, this outline of the brainstem here. And this is the cavernoma here. That's going to be giving a lot of symptoms, but this particular location in the brainstem, you would be very unlikely to ever go chasing afterwards. And the main reason is, if you're the one time you might treat a cavernoma is if it comes out to the surface of it. So if there was no tissue around it at all, like the one I showed earlier. But if there is even just a bit of tissue around the outside of the cavernoma, then even if you can navigate your way all the way to the brainstem, you still need to cut through a bit of the brainstem, and that is likely to have very serious consequences, whether that be paralysis down one side, or trouble with movement in the face, or yeah, it can be pretty much anything. This is another brainstem cavernoma that you might say, well, actually, that was one that you might just be able to remove, because here, again, I've got the outline of the brainstem, and there's a cavernoma invading partly into it, but the main thing is it's also sort of coming out of it. So you don't have to cut through any of the brainstem itself to take the cavernoma out. So that's why sort of, yeah, from a patient perspective, you're like, well, why is that one possible? Why is that not possible? You know, it's a very subtle difference of a few millimeters one way or the other. It can make quite a big difference as a surgeon to whether you'd contemplate it or not. So that's all the treatments. I guess then the last thing to say is, there's some ambiguity when you should use surgery or not. And I probably should say, you'll get the biggest ambiguity is that different surgeons just have different opinions. And that's both different opinions about what the risk the cavernoma poses, but probably the biggest thing is really, whenever you're contemplating surgery for a cavernoma, you're making an individual basis decision on both the appearance of that specific cavernoma for that person and of your ability to remove it. And that judgment of your ability to remove it is, of course, only partly your actual ability to remove it. And the other part is your own perception of your ability to remove it. And there's a lot of subjective bits in that statement. And that's why you'll get different people with different opinions on that. So there is, still some discussion about which ones should have surgery, which should not. And I explained to you before that radiosurgery is really quite controversial because we simply don't know if or how effective it is. As a result of a lot of the work that Cavernoma Alliance has done, there's been a lot of time trying to get that to the top of the priorities for research. And that has finally been funded by the NIHR in a study that's starting next spring, which will be trying to, the study design's got a bit complicated, but essentially if somebody's got a cavernoma and the thought process is, well, I could do nothing or I could operate on it, they will, and the patient's willing to participate in the trial, they will be randomly allocated to either have the surgery or have nothing done. Or similarly, if the sort of quandary is, do I have radiosurgery or do I do nothing? Then if somebody was willing to participate, they would be randomized to doing nothing or having radiosurgery. It's a difficult thing to explain to people because they're big decisions that you're essentially saying, well, I'll leave it to flip a coin. And that's hard to get your head around, but sometimes people are simply in the decision that even without a coin, they don't have any other better way of trying to decide. And I guess looking in the bigger picture, that's the time to consider that sort of trial. I mean, at this stage, that trial is actually just designed as what they would call a feasibility study to see if it's possible to do the trial, essentially around the question whether enough people would be interested in participating or not. So the funding right now is for it to run initially and see if centers show enough interest for it to happen. And then if they do after the first year, then the follow-on funding would carry on for that to happen over what will be quite a long period of time to first get enough people to participate, and then you need to follow them up for a long time to see what happens to them. And that, in a nutshell, I think, is cavernomas. So I guess we're over to questions. Now, I don't know, Joe, how you want to do this. We were talking about it. There's a list of questions submitted, so I'm happy to simply give people's names and let them say their question, which I think is what we were saying we were going to do. So shall I go ahead and do that?
Yep, happy with that, yeah.
So I'll stop the share. And then I need to go to my page where, so I guess the first question I had is from Liana Bai. So Liana, are you there? And do you want to unmute yourself? Silence.
No.
I'll give Liana one more call while I'm looking on my other sheet to see who the next person is on the question list. I have Kay Meredith.
Is Kay here?
No.
No.
Okay.
Next.
Next. I've got Carol Whiting.
I thought I saw Carol here.
Hello.
Carol, if you're... Hi there, Carol.
Hi, hello, evening. Mine was a very simple question, which I think you've kind of answered in your slides, was about having an annual MRI. Was that recommended? Which I think you kind of answered.
I think so. As I say, for the vast majority of people, I don't think it's useful. If for children, definitely. If you had radiation treatment in the past, definitely. If you've got a family history or genetic component, maybe. Yeah, I think that would be in synopsis.
Okay, thank you.
Okay. Then moving down the list, I've got Sam Herbert. Sam Herbert, are you there?
Hello, yes. Can you hear me?
Yeah. Go ahead.
Hi. You answered, I actually sent in a couple of questions, but you did answer the one question. The other question I had was, why do cavernomas suddenly grow? Because I've had one cavernoma for 20 odd years, and then suddenly I've now got three. And I wanted to know, does telangiectasia and DVAs have anything to do with them growing suddenly?
So does that mean you've got telangiectasia and DVAs as well?
Yeah.
And what sort of age are you?
I'm 45 now.
Okay. And they just recently detected that you've got three.
Yeah.
Do you have any idea?
I suddenly had a bleed.
Had you had scans over the years, or was it just that? Okay.
I stopped.
But so we don't really know what.
Sorry.
Do we know when they, because obviously you could have gained the cavernomas potentially 20 years ago and they could have just been sitting there.
No. I've had regular scans.
You've had
regular
scans.
Okay. And then I didn't have a scan for about 2 years, and then I collapsed at work because I wasn't very well, and I'd been having what I thought were ocular migraines, and it turned out I'd had a bleed, and obviously these other two cavernomas had grown.
Yeah. So there's a couple of things. Why do cavernomas grow, and why do you develop new ones?
Yeah.
So growing can be two things. They can sometimes grow simply by having little bleeds. So each time they have a little bleed, they essentially increase in size a little bit, and then that scars up and the scar becomes part of it. So they grow just simply by bleeding, which is different from the actual blood vessels within them growing, which would generally be regarded as extremely rare after childhood.
Yeah, no, the other two have grown in two separate places.
So yeah, and you've not had radiation before or anything like
No,
that?
no.
No. I'm not sure what to say. That would be regarded as a a real rarity. I don't think I have a good explanation why that would necessarily have happened to you.
Oh, right, okay. I think my vascular surgeon's a bit stumped as well then.
Yeah, I think, well, I don't know the details. So you did ask about the DVA and the telangiectasia. So
Yeah,
a DVA, for what it's worth, is essentially a very large vein, and that is essentially kind of part of cavernomas. So it's very common to have a very large vein sitting next to a cavernoma, and all that's doing is draining the blood away from the cavernoma. So the
right.
DVAs are not regarded as anything remarkable. It's just something you often see next to them. Telangiectasia is a little bit different, and that is essentially a different blood vessel disorder, and it does make you wonder whether there is a more general issue with blood vessels, which would also explain potentially why you're one of the rare people who's developed more.
What are telangiectasia then? I don't understand what they are.
Oof, they're essentially like a tiny AVM. So
right, okay.
I guess there's, yeah, if the AVMs I described at the beginning, but then they're really small. So perhaps even way of thinking about it is maybe they're a little bit between an AVM and a cavernoma.
Okay, so it could be the question I need to ask him then is about the I can't say that word, the telangiectasia, perhaps. Yeah. Okay then. Thank you very much.
Okay, then who did we have next? We had Shirley Lyons here. Shirley, are you there? If you are, then unmute yourself, or otherwise I think I can read your question and it might be interesting to other people. She was asking if operations for cavernoma have progressed in the last 6 years. I guess everything makes progress, but I would probably liken it to Team Sky in cycling. We're all still riding cycling road bikes, and they used to go very fast, and they go marginally faster still. And every year, people just come up with a slightly better way of making things slightly better. But it's not massive changes. So, yeah, hopefully that answers that question. Joanne Stewart's next on the list. Is Joanne there? Do you want to unmute yourself?
Nope.
I feel something funny is going on. There's so many people on the line, but maybe the people knew they weren't able to come, which is why they submitted their questions.
Maybe.
Rona Templar, are you there? Do you want to unmute yourself?
Yes, hi. I've got about 5 questions, but I'll try and keep it slightly briefer. And I'm possibly going to be stealing Sheila Templar's, who's on the call as well. But you've answered a couple of them. We've got somebody who's suffered a cavernoma earlier this year in France, who's suffering with terrible vertigo, dizziness, and double vision. Is that a common symptom, firstly, from having had a cavernoma? Or could it be down to the drugs that he's been given to try to get rid of some of the high blood pressure?
There are many facets to the answer to that question. I will try and explain. So first of all, it depends on location. So there are simply some parts of the brain that are to do with dizziness and vertigo. And if those are affected, without doubt, a cavernoma can give those symptoms. Those are quite specific parts of the brain, though. And so the majority of cavernomas will not be in one of those specific areas. Yet, people report those symptoms, and it's the type of thing that doctors don't know what to do with and don't deal with very well, probably, with patients, because practically there's no logical reason why that bit of brain should cause you dizziness or vertigo. Yet, pragmatically, I can say, yes, I hear people say that type of symptom from time to time, even if I can't explain for many of them why that would be the case. probably liken it to, it was on the list of questions, and I don't know if we'll get to that, but it's around headaches. And well, I don't know whether I should tackle that question now or wait for it to come up. So I leave it now and you can ask the rest of your questions.
Well, one of them is about the amount of time it should be, if there is any kind of way of saying how long it should take to start seeing improvement. Because I think it's been probably about 8 months since the cavernoma, the bleed happened, and he is plateauing at the moment and finding it very difficult, obviously, to not see progress. And so
plateauing is definitely what you might expect around this time. Without seeing somebody, it's always very difficult to know whether they're really plateauing or not. And so I would have the observation that often people feel they're plateauing more than they are, in terms that you generally expect to see improvements after this type of thing for up to 2 years. Without doubt, you see the bigger improvements earlier on and they slow down, so there is a plateauing effect. There is a combination between, it's demoralizing to see plateauing, but there's also an element of just perspective that because the improvements start getting slower, people start immediately after getting symptoms thinking day by day. And so you often get people coming like, I got better the first day, the second day, the third day, and then I didn't get better. And they get very worked up about, a few days of no improvement. Then it slows down a bit and things improve week by week. Then they improve month by month. And so often I say to people, you've got to be shifting your perspective. You've got to get away from thinking, what am I like this week to last week? You got to get to thinking about what am I like this month to next month. And often when people are sort of struggling with that, that's what I say. Why don't you just sit down first of each month, write yourself a little diary, write yourself out how you feel today, try that next month. And for a lot of people, that actually is quite helpful to give perspective that actually they are improving, just not as quickly as they were, and possibly not as quickly as they'd want. So, yeah.
Just one final one, and I'll let everybody have a go. I don't, and this is very specific, but whether there is a network of neurologists who specialize in cavernoma, and you happen to know of one in Montpellier in the south of France?
There's no network, so Cavernoma Alliance is about the best organized structure in cavernoma that I think there is. As a result of the Cavernoma Alliance and a bit of a combination with the trial that I was describing before, and the British Neurovascular Group that I'm president of, the number of people who are active treating cavernomas in the UK is reasonably limited. So we probably all know each other and know in which center who would be the person to speak to. So on that level, I can help. On an international level, there's no structure. And I don't know somebody in Montpellier. I only know an oncology surgeon in Montpellier, and that's no help to you at all. If it helped, I can afterwards do some research for you, but that'll have to be offline.
Okay, thank you.
Sorry, I meant to be finding the next person. Margie Foxton is who I've got next.
Yep, she's here.
Hi.
Hi, Margie.
Right. A few of these are very specific to me. So I have ulcerative colitis, and I have to take some medication. I've had a flare-up. I have to take some Mesovant XL, which is an aminosalicylate. That's it. I have to take 4,800 milligrams daily in one dose. But since I was diagnosed with my cavernoma 10 years ago, I've avoided any blood thinners, so ibuprofen or aspirin. So I'm worried, obviously, which doesn't help the condition. Yep. I'm worried that the medication, which will make me better, potentially, will cause a problem with my cavernoma, which is in the brainstem.
Yep, really good question. In some ways, I'll focus it on where we have information, which is, and even then, it's not that much on aspirin and the ibuprofen. Something what you're describing as a drug, there simply isn't enough people on the drug with cavernomas to be able to say in an evidence way there is or there isn't a risk. But to use the example of aspirin, so aspirin is a drug that's known to have some degree of blood thinning activity, and therefore it is reasonably common advice to say to people, well, avoid aspirin and a similar category, ibuprofen and drugs like that. It's not unreasonable advice because, as we say, we know it thins the blood slightly. How much of an effect it has is actually reasonably questionable. And the point being that, when you take these drugs, your blood is thinner, but it's not like it stops clotting. So, if you're on aspirin and you cut yourself, it will still stop bleeding. And therefore, practically, actually, the amount of difference it makes to people bleeding, the evidence for it is pretty weak. I actually do a lot of research on aspirin in aneurysms, where paradoxically in aneurysms, if anything, the evidence is that taking aspirin stops you having bleeds, because aspirin has an anti-inflammatory effect and generally is something deemed relatively good for blood vessels. And that anti-inflammatory effect seems to sort of stabilize the unhealthy wall in an aneurysm. And I'm not saying that's the case for cavernomas at all, but because of that, people with aneurysms who have quite risky blood vessel abnormalities, we quite happily encourage them to take aspirin. Indeed, I'm doing a trial of giving people aspirin for that purpose. So although that's anecdotal of a different disease state, my point is that the aspirin and the ibuprofen probably don't have anywhere near as big effect as people would imagine. And with any of these drugs, I'd say, you need to look at what is the need for them. And if there's a good need for them, I personally would take them. Now, so I guess the way to think about it is, well, if you've got a bit of an ache in your knee or your shoulder, probably could manage without the ibuprofen, maybe try a different drug. But say you're somebody who's had a heart attack, who would genuinely benefit from the aspirin, I would overwhelmingly take the aspirin to prevent yourself having another heart attack. And I think I'd liken it the same way for you specifically for the ulcerative colitis, that if that drug helps you for the ulcerative colitis and that's clear cut, then I wouldn't overthink what it might do to your cavernoma.
Okay, thanks. I have got one other question. So I was diagnosed 10 years ago. I've had gamma knife surgery 10 years ago, very shortly after I was diagnosed, because my brainstem cavernoma was symptomatic. So I didn't realise at the time, but I'd had various episodes that my neurosurgeon could almost pinpoint when I'd had these very small bleeds. I've had a couple of a bleed about 8 months after I had the gamma knife surgery, another one that the whole of my left side of my body I lost sensation in. And then I've had another bleed 3 years ago or 4 years ago after an exercise class. I've never really been told what I shouldn't be doing. So lifting heavy objects, exercising, blood pressure, things that do increase my blood pressure, long haul flying, things like that, which sort of terrify me.
No, a good question. And you said at the beginning, oh, these are very specific questions to me, but these are probably some of the most common questions you're going to have about cavernomas. To put it aside first, flying, not a risk at all. So simply I can't think of ever seeing a patient with a cavernoma who had their bleed on a plane. And again, it's useful using analogy from different blood vessel abnormalities because the situation is more stark. So an brain aneurysm, which is a way more dangerous thing to have, present in 3% of people. So on an average 747, there will probably be more than a dozen people with an aneurysm. I'm to date to meet somebody whose aneurysm burst on a plane. So planes, not an issue at all. The other group that you're talking about is exercise, and specifically basically putting up your blood pressure. That's a harder one to answer, and so a lot of people will caution and say, well, avoid things where your blood pressure goes very high. I'm a pragmatist in that on two levels. First of all, because you can't just control your blood pressure all the time, and secondly, you have to lead a life, and it can be very debilitating walking around everything. What's this going to do? What's that going to do? And the way I try and liken it to people is the problem of a bleed happening is because there's a weakness in a blood vessel. And yes, that can be exacerbated by blood pressure going up, but ultimately the problem is the weakness of the blood vessel. So if you liken that to a tree or a house, or but say a tree that's old, that tree is going to fall over at some point. Now, that might happen slightly earlier because there was a storm slightly earlier, but it's not going to change that the tree is going to fall over. And so with the example of a cavernoma, I'd say, look, you could do everything to prevent your blood pressure going up, and you might stall a bleed happening by a day or two, but I don't think it's going to change that it's going to happen in the end. And if you look at your blood pressure, just when you cough or you go to the toilet, your blood pressure does massive spikes, really big, probably much bigger than exercise and things like that. So you're never going to prevent these spikes. And to try and do that, you would, you potentially, some people can really cripple themselves by avoiding things. And it doesn't take into consideration the other side of the actual health benefits of the exercise and things. And so again, I'm a fairly pragmatic sort of person. My view is, yes, there is some degree of concern there, but actually you're going to do yourself much more harm trying to avoid all these things than the benefits of just living and enjoying them.
Great, thank you.
Okay, Carl Hudson. Carl,
Hello?
if you're there, hi.
Hi. I had some seizures in January. They were my first ever. I had two in the same 12-hour period, and I've been classed as epileptic for it, but I have been put on medication. My first question, I guess, is, am I actually epileptic? And my other question is, do I need to remain on my medication, which is, excuse my pronunciation on this, levetiracetam?
Levetiracetam. Yeah, so whether you have epilepsy, that's all about definitions, and epilepsy is simply anybody who has multiple seizures essentially has epilepsy. So I'd consider you to have that. In terms of staying on your medication, your chance of having another seizure off medication is extraordinarily high. So the statistic I gave earlier, that was at 94% of people who've had one seizure will go on to have another. If you've had two, it's fairly well inevitable. So I would definitely stay on the medication.
No, that's brilliant. You've answered my questions there. Thank you very much.
Okay, no problem. Peter Barney, you there? You want to come off mute?
Nope.
No. And then the last one I have on the list is Sarah O'Dare.
Hi there.
Hi.
Hi. You've touched briefly already on headaches, but I just wanted to know if migraines are linked to cavernomas, and if not, can you explain why? I've noticed that lots of people seem to have them that also have cavernomas, and curious just to know the link, really.
Yeah. So I haven't really answered the headache and migraine question. I actually left it because I had seen your question at the end there.
Thank you.
First, we've got to distinguish headache and migraine. So migraine is a specific type of headache with an aura and associated symptoms. If you look at how doctors traditionally look at headache, they simply say it's unrelated to cavernomas, and the main reason for saying that is that the brain has no sensation in it. So there's no, although the brain is made up completely of nerve cells, there are no nerve cells that feel pain in it. And indeed, we can operate on the brain under local anesthetic and cut parts out of it, and people don't feel it. So on that basis, people simply generally say headaches are not related to cavernomas. That's a nice, easy message as a doctor to give. There are probably subtleties to that. And I think as a broad brush thing, most headaches probably are unrelated. The vast majority, headaches are common, and so therefore it's inevitable that some people with cavernomas are going to have headaches. There probably is more to the story. So some people probably do get headaches from cavernomas. The mechanism through which is probably a bit uncertain. Some will be directly because they've just had a bleed, and sort of the pressure from the bleed, the brain, although it can't feel cutting as it were, it can feel pressure. So that might be one reason. That wouldn't really explain more chronic headaches, which can be caused by irritation of the lining around the brain. Even if you can't really explain it, there probably are some people who just seem headache prone, in which it potentially is related. The question is, what does that mean, and would treatment help you? And the reality is probably not, because again, the treatments can cause headaches as well. And I think, was it part of your question? Yeah, how do we know that cavernomas aren't related to headache? I guess the only way to really work out whether cavernomas cause headaches would be to operate on a lot of people who've had headaches and had a cavernoma and see what happens afterwards. Nobody's ever done that study properly, largely because nobody operates on vast numbers of cavernomas. But the sort of observation you have is, if you operate on these things, is that the occasional person will report that headaches are better, but the occasional person afterwards will also report that they've developed new headaches after an operation. And therefore, when you're using the sort of averaging what on average happens, it's not obvious that you make much difference. I'm not sure if your question related more specifically to migraine than headache, realizing I've just talked all about headache in general. Were you asking more specifically about migraine, or?
Yeah, I didn't really want to go too much into my own personal situation, but I'm diagnosed with 2 cavernomas in my brainstem recently, in my pregnancy this year, and I've suffered all my life really since 13 with debilitating headaches that have just, well, they've been diagnosed as migraines, but they're just consistent now that they're, every 2 or 3 days. And I just wondered if there was a link really to the cavernomas.
And do your migraine, are they in any way typical for migraine, that you get a sense of them coming on and you get visual disturbances and things like that?
No, I don't get the visual disturbances. I have it behind the back of my eye, my left eye, and around there, and also at the back of my head.
Okay. So, I mean, it isn't classic migraine symptoms that you're describing. I would say that a cavernoma in the brainstem, I wouldn't expect to cause migraine. Migraine is typically a pain that is associated with abnormal electrical activity over the surface of the brain, and so away from the brainstem. I think for your, just if we just relate it to be calling it headaches in general, the answer I gave before is what I said, is that there's really no way of finding out whether your headaches are related or not, other than to remove it. And because we make as many people worse as we make better with headaches, it isn't really justified doing that as a reason.
Yeah. Okay. Thank you very much.
Okay. I think that was the last name I had on the list, but I think there have been hands up. So I don't know, Joe,
Yeah.
if you've kept track of who else.
Yes, I've got a list here. Peter Barney is actually here. I don't know whether he heard you call his name for a question. Did you want to ask a question, Peter?
Yeah, I couldn't unmute things.
That's okay.
In time, anyway. Right, my question really, I've got cavernomas which have been caused by radiotherapy years ago, and one of those bled recently. And my question is in any way the behaviour of a cavernomas by radiotherapy, is it different from the behaviour of cavernomas caused by well, any other reason?
Yeah. So the short answer is yes, they are different. To clarify, any other reason basically means no reason, because the vast majority of cavernomas don't have a reason. So the kind of, if you're going to say for reasons, there's either no reason, or it's genetic, or it's radiation, and radiation is the rarest of those. And yeah, I'm afraid the ones with radiation are the ones that are more likely to grow and bleed of those three categories.
Right. And one more question. I think partly answered by someone asked by someone else, but is there anything particular I should or shouldn't be doing as a result of cavernomas by radiotherapy, or caused by radiation?
So I don't think there's anything specific about it being due to radiation that I'd give any
Right.
different advice.
Okay.
And the broader thing about cavernomas, you're asking things to do or not do. As I said in the previous answer, I'm pretty pragmatic. I do most things. Probably the one exception that we didn't mention in that is people who have seizures. There are reasons, things you should not do because of the seizures, not necessarily because of the cavernoma itself.
Yeah, thought so. Okay, well, thanks very much. Thank you.
My pleasure. We got a few more hands, Joe.
Yep, we've got Daniela and Russ. Are they here?
Hiya. Yeah. So it was two questions. First of all, and I think Rona already asked a similar question, but it's and I think you may have already answered it, but is it normal for the cavernoma to cause dizziness, or is it more likely to be seizure medication, in particular medications such as lamotrigine and cemiplimide? I'm not sure if you're familiar with those.
If you're on seizure medication, it's overwhelmingly likely to be the seizure medication. So they're particularly balance problems are quite a common side effect from those.
Right. Okay. So it's much less likely to be the cavernoma itself.
Yeah. Yeah.
Okay. All right. Great. Thank you. And the second question was, how common are focal seizures, and why do some people get painful symptoms and others don't? Because the focal seizures are very painful. And what would influence that, if anything?
Okay, so the first part, are focal seizures common? Yes, they're very common. Yeah, for people who don't know the difference between focal seizures and the other ones that we call generalized seizures, focal seizures is where the brain immediately surrounding the cavernoma gets overactive, and therefore only a very specific part of the brain is affected. So you might get shaking of a specific arm, but you might stay conscious through it, for example, which is different from a generalized seizure where the whole brain starts getting overactive and you lose consciousness. And both types are common, but partial seizures are particularly common with cavernomas. You asked about them being you're saying that your seizures are painful.
The focal seizures are quite painful. Yeah, it's my partner Russ actually. But yeah,
Okay.
his seizures, his focal ones, he's still conscious, but they are quite painful.
And they're painful in the muscles that are spasming specifically, or a different type of pain?
Yeah, on the whole, sort of the whole left side goes numb, and it feels. Yeah, I mean, do you want to explain it? Sorry.
So
yeah, no. So I usually start about 19. I got like a mild tingling in my left fingers, but as I've got older, I'm 27 now, and I only get them at night now because I'm on medication. But it's I get like a real painful symptoms all through my left hand side. Yeah.
And is that possibly because the actual muscles are going into spasms to the degree that they hurt? Which
yeah,
that would be the most common cause of pain associated with seizures. That essentially the muscles are just being hurt by straining so much.
Okay, thanks.
Okay, so it would be more sort of not the nerves necessarily, but the muscles cramping up.
That would be the most common reason, yeah.
And the reason why it's gone from sort of a tingling only to the whole left side, is that quite common as well, that it would sort of spread?
It's essentially, the seizure activity is becoming more pronounced with time, it sounds like, from what you're describing.
Yeah, even though regardless of the medication, it is, yeah.
Yeah, and so the likelihood is that there has been some degree of additional scarring over the years that's led to that, and so that the underlying amount that his brain wants to seize is more, and therefore, even though he's on the medication, he's getting more symptoms.
Okay, all right, thank you.
Thanks.
Hi, we've got a Martin. I haven't got a surname. Is Martin here?
Yes, I'm here. Thank you,
Yeah,
Martin.
there you go.
Thank you. Hi. I have got a cavernoma which was bleeding in the last 6 months or so. It was discovered incidentally. I didn't have seizures or anything, but in that time, or since that started, I seem to have a linkage to a loss of short-term memory, and also some confusion, which some days more than others. I'm a lawyer and not used to being confused, and mentally sort of usually quite alert, but I have days where I just can't work. And also a sensitivity on the left-hand side of the skull, which seems more linked to movement if I stand up suddenly or moving around. I just wondered, sort of, I'm actually having mine scanned shortly again, but it's, as I said, it's near the motor cortex, so there are issues with dealing with it, as you went over kindly during your talk.
So I think the first things you're asking, are these common symptoms? They are surprisingly common symptoms after a bleed. I hesitate a little bit because with bleeds from other causes, again, and I make my comparison with aneurysms where the bleeds are large, these are particularly common symptoms. So if you see somebody who's had an aneurysm bleed, they'll all have fatigue, they'll all have trouble with short-term memory, and they'll all get muddled. Absolutely classic. The reason I hesitate is because I can't say I've ever really fully understand why we see it in people with cavernomas, because the bleeds are so much smaller, and they're usually quite localized. So unless the cavernoma is in a specific part of the brain that's associated with memory, for example, you wouldn't really expect to see it. So I showed a slide early on of a cavernoma in the medial temporal lobe, which is a particular area associated with short-term memory. So if it was in that location, you say, yeah, it makes sense. That's the bit that serves short-term memory. But for some reason or other, cavernomas that bleed elsewhere in the brain, it's very common for people to say to me that they feel tired and get a little bit muddled, and the memory's not quite right. I have no logical reason. I mean, I guess the small amount of blood that's released must somehow be dissolving and causing some disturbance to the brain more generally. But yeah, pragmatically, people report it all the time.
Thank you. And is the sensitivity on the scalp like a tickling sensation? Is that something unrelated, do you think, or could have a relationship?
It's in the same category. I cannot explain why people report it, but you're not the first person to say it to me.
Thank you. Okay. Thank you very much.
Have we got Janet Bunch next, if you've got time? Janet?
Hi.
Hi. How can I help?
Yeah, so my question was really about, I presented with stroke-like symptoms, tonic-clonic seizure, you know, all the rest of it, and they found it and they put me on epilepsy medication, and they were scanning me every year, which was great because it gave me some comfort. At my last scan, they told me that I developed a cyst attached to my cavern, and that they weren't going to scan me anymore because whether it's general medical council or whatever, but basically it had all changed, and that there were no further scans being done because I'm a sort of watch and wait because it's too deep to operate. But my worry is, how big can this cyst get before it becomes a bothersome issue?
Yeah, tricky one without seeing the scan to really know what to say. Most likely what a cyst would related to a cavernoma would be where there's been a bit of bleeding, and that blood then resolves, and that cavity that it creates essentially ends up being filled with fluid, and a cyst is simply a little fluid-filled cavity. So there's no particular reason why it should continue growing, but you know, it's obviously formed, so it is possible it could. With what you refer to with the scans, I guess this is the difficulty where people aren't sure what to do, that you get crossed wires of different approaches to something. I think in the past, there was probably more variation in what people did. So I think a lot of people got a fair bit of disservice having a cavernoma, and then a few people got through and then got themselves into sort of regular scanning protocols. The reality, as I said, is on average these days, most people would not follow up a cavernoma, and I presume either specifically the doctor that was looking after you has sort of aligned to that, or I don't know if there's been a change in the person who's seeing you, and therefore as a result of seeing somebody different, you've ended up with a different answer.
Right, okay, thank you.
Yeah, okay.
How are you doing for time, Mr. Bulters? Have you got time for a couple more? Or?
Yeah, there were two hands left.
Yeah, I think we've got a Deborah Fox. Is she still here? Deborah?
Yes, hello.
Hi.
Hi there.
Hi. I'm speaking for Mark, my husband. Mark has had a brainstem cavernoma removed 5 years ago. It was a partial removal in the end. And our question is, can it grow again and become symptomatic? Can it bleed again? And because he has had radiosurgery since as well. So I guess it has caused symptoms, but what I want to know is, could it still have the potential to bleed further?
Well, there's two parts. Can it grow and can it bleed? I guess both are possible, but I would say growing is unlikely, just on the basis what I've said before, that although we've mentioned a few that have grown, it's really quite rare to see cavernomas grow, particularly if you're older. The chances of bleeding, they don't completely go until it's all gone. But I suspect that if you've had both surgery and radiosurgery, that your risks are, reduced massively. And I don't know, how long is it since your last bleed now?
3 years.
3 years. So as I say, the main risk of having another bleed is in those first 2 years. Once you're through the first 2 years after a bleed, irrespective of whether it's been treated or not, your risk of another bleed starts dropping to just a percent or two per year.
Okay, thank you. Great.
Okay. Does that mean we're on to the last hand?
I think so. We've got a Sunel. Is it Sunel's hand that's up? Sunel Abram?
Yeah.
Yep.
Hi.
Hi there.
Yeah, hi. Mine is a little bit in dilemma at the moment because I had a bleed in January 2020, and after the MRI, they found out how bad it was in the pons in the brainstem. After the MRI, I was given a lot of treatment with neurophysio. They came and did that for 6 weeks, and I've been doing yoga and meditation. Now, thing is, it's a remarkable recovery. I'm absolutely fine. However, because it's in brainstem and where it is in the pond, I'm in dilemma whether to go for this radiosurgery or whether to leave it until another year to have a scan, like you mentioned in your talk.
Yeah. So you're asking, what would I do?
Well, you see, the two MRI shows it was 28 millimeter. Now it's reduced to 22 millimeter in September.
Yeah.
So I have no kind of functional problem or any other problem. So I'm really in dilemma now what to do.
Yeah. So the first thing that just to mention, because I think people might be wondering, because you just said it shrunk from 28 to 22 millimeters. That's almost certainly because some of it was, you'd had a bleed and the blood sort of made it expand up a little bit, and that blood is now reabsorbed, and therefore it's shrunk back. So it's not that probably not that the cavernoma itself has shrunk. It's probably just that the blood is dissipated.
Yeah.
I personally would wait it out if you've had one bleed. So my own rule of thumb is that I would rarely treat anybody with one bleed because there's a reasonable chance they never have another one. And I would consider treatment after 2 or even 3 bleeds. And probably the most common point at which I would undertake things is after 3. And the thought process there is that either you're talking about surgery, in which case, as I said, the risks are really quite high, or you're talking about radiosurgery, which is much less risky. But I have to declare I'm at the more skeptical end of I think radiosurgery probably does do something. I just don't think it's an absolute, it doesn't get rid of all the risk. And therefore I tend to reserve both treatments really for when you've really tried without, which is 2 bleeds.
Yes, it's just my consultant says that if I go through this process of radiosurgery, and if it suppose within 2 years you wouldn't know, and then within that time, if it bleeds in between, you can't actually go through the proper surgery either. Is that right?
I think that'll be a personal opinion. So I must admit, if you had, you're saying if you had radiosurgery, then would that stop you from having surgery? It wouldn't in my hands. So I wouldn't be put off by having, but the bigger question is, if I thought it was something that I could feasibly operate on, I probably would be doing it from the outset. And if you're talking about doing radiosurgery from the outset, it's probably because your surgeon thinks that surgery is, quite an undertaking.
It's just that where it is, if it's in the pons, then you have to go right inside, isn't it? In the brain.
Yeah, it's a long way inside, and as I explained, it's very subtle on the scan, depending exactly where a few millimeters here or there in that area make a big difference to how feasible it is to operate.
Yeah, exactly. So that's my worry, that if I wait for the surgery, then it if they have to cut through the brainstem, that's more risky. That's like 1 in 20, isn't it?
Yeah, no, I say if I were in your boots, I would probably hold tight, and if there was another bleed, consider radius surgery at that point.
Okay, that answered my question. Thank you very much.
My
Great.
pleasure.
Thank you.
Right.
I think, we there?
Yeah, there is a few more people wanting to ask questions, but I was conscious of how much time. I know you told your wife you'd be done by 8:30, didn't you?
I did promise I would be done. How many questions have we got?
I've got 3 on my list still.
Okay, should we do those 3 and draw a line out to any
We'll do
latecomers
those
after that?
3. Yeah, anybody else that's got questions, if you email them through to me, we'll get a response back to you, and during the week. And I apologise that we've run out of time. But the first one was Sheila. I haven't got a surname. Is she still here, Sheila? Is she here?
She is here, but her microphone, sorry, she's my sister-in-law. Her microphone's not working. So if you've got the question there, is it possible to read it out?
I haven't, no. I got a question through on the chat.
Right.
Do you want to have a look for it, and we'll do the next one?
Certainly,
Is that okay?
thank you.
Yeah, okay, so we've got Georgina Legg. Is Georgina here?
Yeah.
Yep.
Hi. Hi.
Hi there.
Hi there. My question is to do with my cavernoma in my brainstem, which was diagnosed 16 years ago. And I've had 3 bleeds, which were all in the first few years. But I've noticed just recently, in the last couple of years, I've had a new sensation. Majority of my problems have been dizziness and vertigo, but I'm now getting this sensation where if I wake up in the night or wake up first thing in the morning, I can't work out if I'm upside down or if I'm the right way up. It's like my brain doesn't know which way up I am until it takes about a few seconds for it to understand where I am, if that makes sense.
Yeah, yeah. And does that come on gradually, or is that sort of something was there one day?
No, it just started to happen one day. Like I said, probably about 2 years ago, and it's always in the night if I wake up or first thing in the morning. Once my eyes are focused and I can see, I kind of can work out if I'm the right way up or not.
And you're asking whether this is related to your cavernoma or not?
Yeah, yeah.
I mean, it's an odd symptom, but the brainstem has a lot of function in it, and I wouldn't be amazed if it represented something very small happening. But there probably is not many ways to prove it one way or the other. And I think I would say you're actually a pretty good example with what little I know about you for the advice that I was actually getting to the previous lady, that you had 3 bleeds, but you look pretty healthy, and you've had 16 years since then. I assume that have been all right for you.
I am actually in a wheelchair.
Okay.
It was quite a severe bleed, which left me with quite a lot of neurological problems. I can walk a little bit, but the majority of time I'm in the wheelchair.
But you've not had anything significant for 16 years.
No, just ongoing stuff that I've been left with, really.
Yeah. So, the question is, how much could you prevent it if you've not had anything else happen during that period of time?
I'm definitely pleased. If it helps anyone, I'm glad that I chose not to go with surgery or radiosurgery. Well, actually, surgery isn't offered to me. It's too deep down in the brainstem. Radiotherapy was offered, and we decided not to do it. And I'm glad I did that now, if that's helpful.
Okay.
Just a quick question, as Georgie's husband. Do we need to be thinking about COVID extra with people with cavernomas? Do we need to be worrying about it more, or is it just the same as a normal person?
I don't have no specific thing about cavernomas. With our brain surgery patients in general, we're not giving any specific advice.
Okay, it's just because our son goes to school and we don't know whether to leave him at school or to pull him out, or just if it's not linked to anything like that, then we just leave him, I suppose.
I think I would just follow the rules basically as they're set at the time by the government at the moment the kids are going to school, and I'd go with that.
Okay, thank you.
Thank you.
Okay, we've got Dita Purcell. Is she still here? That's you? Yeah, you're on
Hi.
mute, Dita. You're on mute.
Sorry. Good evening. Sorry, make me jump.
It's
Yeah,
okay.
so, my 12 years old's been just diagnosed with cavernoma because he had a few seizures at night, and we wanted to ask mainly because we were told for him to stop doing rugby and any contact for contact sports for some time. Is it something you would recommend as well for him?
So I wouldn't recommend against contact sports. Pretty much, there's no evidence at all that trauma causes. If you're going to choose something to avoid, well, aside from that, rugby being a dangerous sport and it causes head injuries, so as a neurosurgeon, I'm not a big fan of it. But that's got nothing to do with the cavernoma.
Yeah.
So I think there's no concern specifically cavernoma with contact sports. If you were going to make any argument for anything, you'd make more of an argument over blood pressure than you would contact sports.
Exactly what you said.
The bigger picture thing, though, is the seizures really determines what sports he can do largely, because you would be avoiding sports where you could injure yourself. For example, swimming, you wouldn't want to do if there isn't somebody in attendance in case you had a seizure while you're swimming.
Yeah, that's right. Yeah, thank you. We've advised that as well. Another question from his report is he's got few cavernomas around his brain, about 3 or 4. What is the prognosis with those? Is it something that they could grow bigger?
He's 12, you say. So I mean, I think by that age, the chances of growth are getting lower, but they're not zero. So I generally, in my mind, consider them to grow with the human being, and therefore the risk carries on until your adulthood. But the reality is the ones that you see behave most peculiarly are the ones in the younger children.
Okay, so that's my husband was actually asking, what do you consider by child? He's going to be 30 next weekend actually, so his brain is still growing, but the risks are lower than if he was, say, 5 years old.
Yeah.
Yes, sir. All right, lovely. Thank you very much. Thank you very much for your time. Really.
My pleasure.
Okay, and the last one, should we just go back to Sheila? Yeah, are you ready, Rona?
Well, actually, what I was going to say is I'm going to let you all off. If it's all right, we'll email our final question, because partly I don't want to pronounce the drug names, but also it might be easier and we all need to have some supper. But I want to say a huge thank you. That was brilliant, really helpful.
My pleasure.
Okay. There are a couple more, but I can forward those on if you need to go, Mr. Bulters.
Okay, I think probably best. Otherwise, I might have an unhappy household.
Yeah, I think you'll be here. But yeah, apologies to those that didn't get to ask their questions. We just email them to me. I've put my email address in the chat box, and we'll do our best to answer those as soon as possible. But thank you very much for giving up your time, Mr. Bulters. It was a great presentation as always, and I hope we've had great feedback in the comments about how informative it is, so thank you very much, and we hope you'll come and do it for us again.
Yes,
you can fit us in.
If it's helpful, very glad to do so.